The overall efficacy and survival data for the AURA-1-2 study with longer follow-up is consistent with what has been reported for osimertinib. And we look forward to the final overall survival data from FLORA study, because that is important if osimertinib can demonstrate overall survival benefit over first-generation EGFR TKI. I think that's important, and based on a phase 3 study. So we look forward to the data, hopefully very soon. As expected, the higher dose of osimertinib, 160 milligrams, had more side effects than the 80 milligrams osimertinib. There's slightly more diarrhea, more stomatitis, more paronychia, and more patients have to get a dose reduction from the 160 milligram cohort. The optimal use of osimertinib in EGFR mutant lung cancer is the first-line upfront use of osimertinib. I personally believe that because of the superior progression-free survival, the much better tolerability of osimertinib compared to first-generation EGFR TKI, and the superior CNS activity, those are the three major reasons that I will use osimertinib upfront in EGFR mutant non-small cell lung cancer. I will not wait to sequence. The resistant to osimertinib is heterogeneous. We will have to get a repeat biopsy to understand the resistant mechanism and tailor the treatment towards separate resistant mutations. Chemotherapy is always an option post-osimertinib. Additionally, you can combine osimertinib with chemotherapy, which is not the recommended. I don't recommend it, but I know that clinicians do use that. It's easily combinable with carboplatin and pemetrexed. So I hear some clinicians are reluctant to use osimertinib upfront because they worry about what happens after osimertinib failure. But given the heterogeneous resistant mechanism, we need to test. If you have a resistant C797S mutations, you can use chemotherapy. There are other antibodies that can target the EGFR that can be used. If you develop a MET amplification, osimertinib has been successfully combined with MET inhibitor in both clinical trials and case report settings. So that's you can use the combination. And if you have other bypass pathway that is not amenable to targeted therapy, you can use chemotherapy. And if you have developed a ALK fusions or a RET fusions, we, together with other investigators, has published combination of ALK TKI with osimertinib or RET TKI with osimertinib, and have been able to successfully treat the patients who develop resistant osimertinib. I actually have one patient who is still on a RET inhibitor with osimertinib. It's part of the study by Alicia Sequest and Social Stroker at the Cancer Discovery paper. And she's still doing well with a combination. So there are lots of ways to overcome resistance, and I would not hesitate to not use osimertinib upfront. I would recommend to use osimertinib upfront when you have a patient with mutated EGFR mutated lung cancer.